Well, welcome everybody. Today is July 24th, 2018. I'm Randy Wong. I'm a retina specialist just outside of Washington, D.C. What we've been doing over the last 6 months is a webinar every other month for the treatment of floaters. And you can follow us on vitrectomyforfloaters.com. You can also follow me at retinaeyedoctor.com as well. Special thanks to Chrissy, who has organized in this meeting and got us together. Excuse me. So let's get started. So I'm Randy Wong. I'm a retina specialist located in Fairfax, Virginia, which is just outside of Washington, D.C. by about 20 minutes. These are my two principal websites. The nitty-gritty is we have to go through the disclaimers, which are that this webinar is for informational purposes only. This webinar does not offer medical advice, so nothing should be construed as medical advice. The information on this webinar is only offered for informational purposes. You should not act or rely on anything in this webinar or use it as a substitute for medical advice from a licensed professional. The content of this webinar may quickly become outdated, especially due to the nature of the topics covered, which are constantly evolving. The materials and information on this webinar are not guaranteed to be correct, complete, or timely. Nothing in this webinar and nothing you or I do creates a doctor-patient relationship between you and the webinar, between you and me, or between you and Randall Wong, MD, or retinaeyedoctor.com, or vitrectomyforfloaters.com. Even if you try to contact me through this posting of the webinar or conversations through the webinar, you are not creating a doctor-patient relationship. Although I am a doctor, I am not necessarily your doctor until and unless there is a written agreement specifically providing for a doctor-patient relationship. And there's the nitty-gritty. So what I'd like to do tonight before I open this up to Q&A is give a few slides on the nature of the vitreous, the definition of the vitreous. I want to go over the definition, the anatomy, and quickly discuss the purpose and the function of the vitreous. And I kind of surprised myself. I was thinking of what should we talk about Tuesday night, and here we are. I think I've never talked about simply the vitreous. So that's what I'd like to go over in the next 2 or 3 minutes before we open up to Q&A. Incidentally, what we're going to try to do is limit the whole course to about 30 minutes. This makes it easier for everyone to digest on YouTube, and it also shortens the amount of production work we have. So the vitreous fills about 80% of the eye, and it fills, as most of you know, it fills that area between the lens and the retina. So it occupies that area where in the illustration where you see floaters and vitreous. The vitreous is about 98-99% water. The other 1 to 2% is composed of a protein of various types of collagen. It is supposed to be optically clear. The index of refraction of the vitreous is basically the same as water. So as you know, you can see quite clearly through a glass of water. You should, and in most cases, everyone should be able to see through their own vitreous as though they were looking through water. Now, there's a lot of question as to what the vitreous is attached to. The vitreous is sticking to or attached to, number one, the optic nerve. And you see that labeled in the illustration. Number 2, the macula, which is the same as the fovea. Number 3, all those squiggly red lines are retinal blood vessels. So the vitreous is actually adherent to the retinal blood vessels. So the 4 places are optic nerve, macula, retinal blood vessels, and the vitreous base, which is what I'll show you next. So here's the 4th place. It's hard to see, and it may be difficult for you to conceptualize, but the vitreous base is basically the anterior adherence of the anterior vitreous to the anterior retina, as shown with the blue arrows. So in this area, in the front of the eye, the vitreous and the retina are very adherent, and it's almost impossible to surgically or naturally separate the two. Everything below in the back half naturally separates, especially when you create a PVD or when a PVD naturally occurs. So the vitreous base is this anterior area here, which is always probably going to be adherent. Last slide is purpose and function of the retina. The vitreous main function is that it allows for the development of the eye, so that embryologically speaking, the vitreous is a key component to the developmental process as we're developing as a baby. Once we're born, there's no proven physiologic function. I stress the word proven. What's the function of the vitreous? Well, we know there's an association with various retinal pathologies like retinal tears, macular holes, or epiretinal membranes. There is some pathway or there's some mechanism by which the vitreous is related to these functions. The way I look at the vitreous is, if it weren't for the vitreous, there would be no surgical. Let me put it this way: all surgery related to the retina can be related to the vitreous. I think somewhere it's involved in the pathway. We don't know exactly if there's any principal reason other than if an eye were to get sliced open, that the vitreous could kind of plug that hole. There is a question and there's a suspicion whether or not the vitreous actually plays a metabolic role in that. Does it consume oxygen, and does that function of consuming oxygen play a protective role, say, in cataract formation? There's evidence that perhaps it does, but it has never been proven. So having said that, what I'd like to do is let's open this up to Q&A. The best way to do this for the next 20 minutes is if you can type your questions in the chat area. I'll read them aloud, and we'll try to get through as many as we can. So first question is, at what level is nearsighted an issue? -325 in my floater-ridden eye. I'm not concerned with nearsightedness at -3.25. I might be concerned if you were like -20. There is a direct correlation to the amount of nearsightedness and the actual length of your eye, so that if you're -20, your eye is much longer than, say, your eye. And sometimes it can be an issue as to whether our instruments can actually reach back to the posterior part of your eye. Hazem says, I'm suffering from retinal dystrophy. I'm sorry to hear that. I don't know if you're asking a question about that. Next question. I have a large cup of optic nerves. This is an issue to prevent FOV for floaters. I have a large cup of my if you have a cup, you're talking about the appearance of your optic nerve, I'm guessing, and that perhaps you are someone thinks you may be a glaucoma suspect. Generally, when we use the terms cup, it refers to the optic nerve and your chances of having glaucoma. Next question is, do you replace vitreous with saline or an air bubble? I do not use air unless there is a retinal detachment or macular hole. So the answer to your question is no. I usually replace the vitreous with saline, and that saline is reabsorbed or replaced within 24 to 48 hours. Edwin says no, glaucoma is from birth. I don't believe that would be a contraindication for having a vitrectomy, though. Hazem says, seeing floaters and flashes all the time. Can you re-ask that? I don't really. You want to know how to stop them? I guess I'd have to examine you to determine exactly what the floaters and flashes were. The smartest thing I can tell you right now is if they're bothering you, make sure that you get examined by an eye doctor to make sure that we're not dealing with a retinal tear or retinal detachment, or maybe even something like uveitis. Um, I don't know how to tell you to stop them if I don't know the cause. Joanne says, I want a PVD induced. Do you end up doing so in most cases? Yes, I do. PVDs allow me to operate more efficiently and get more of the vitreous. In my opinion, if you do that, it also decreases the chance of frill, especially if you're a young patient. It is a safer, in my opinion, way to proceed as far as reducing complications from the vitrectomy. Linda says, does insurance, Medicare cover this procedure? As far as I know, Chrissy says, yes, Linda, email me directly for more information, but it is considered medically necessary. Yeah, and that's been our experience, is that I don't think that we've had any insurance deny this procedure. Last week, Soon says, last week I suddenly had a lot of floaters, black dots, frills in my right eye. Eye doctor said they were due to PVD, no retinal tear. I am considering FOV. Should I wait a few weeks, months for PVD to settle, stop, so that the FOV can be safe, or it shouldn't matter? For lots of reasons other than you stated, I think the best thing to do is wait several months. If you are, I mean, I don't know how old you are, but if you've been dealing with this for 6 to 9 to 12 months, certainly longer than 1 week, then I would encourage you to investigate therapies. But I think right now I would not recommend surgery because this just happened and things can resolve. I'd be more concerned about your chances of developing a retinal tear or retinal detachment. Short answer is I would wait. Edwin says people with allergies or chalazion history are okay for FOV. In general, the answer is yes. Tuan says, I had vitrectomy surgery for floaters 3 weeks ago. PV was induced. I still have one long transparent floater remaining on the right side of my vision. If I do a second FOV to clear the leftover floaters, are the risks greater than the first surgery? The only chance, in my opinion, and I didn't do your first surgery, it's been my experience that second operations, third operations, they increase the chance of cataract formation, because what it means is that we need to be more aggressive in removing remaining vitreous. And usually that vitreous is very, very much in the front of the eye. And if our instruments touch the lens, you may get a cataract. And, that's happened a few times over the last couple of years, all of them in repeat surgeries. On the other hand, it really depends on where that remaining strand of vitreous may be. I've had a couple cases where even though we induced the PVD, we were surprised to find a couple strands of vitreous adherent to the retina in the back, and we easily remove that. It's hard for me to conjecture, having not ever seen your eye or know what's going on, so I can't give you a real definite answer. Soon says he's in his 50s, so that I think that there's a good chance, because you're older, that the floater may move to a different part of your eye and become less bothersome. Linda, you keep sending me a one-letter note, and I don't know what it means. Soon, did you say I should better wait for a few months for FOV? I think you should wait lots of months. And that's why I said if in 6 to 9 to 12 months this is still bothering you, then consider getting an operation. But your concern right now, because all this happened, is determining what your risk is in the next 1 to 2 months of getting a tear in your retina or retinal detachment. And you need to kind of listen to the advice of your doctor that you saw last week. Joe says, any questions that you recommend patients ask when coming in for a consultation? I don't think there's any questions that you really need to ask, but I stress with everybody that I meet in person, our goal of surgery, the goal of this is to significantly reduce what ails you. And if you're complaining about these floaters in your vision, the idea is to significantly reduce those floaters or remove them completely. But the goal is to significantly reduce and do so without causing harm. That's the objective. Edwin says, if the floaters are close to the retina, is that okay for FOV? Yes, especially if we're going to induce a PVD, because the proximity to the retina then becomes obsolete, because I don't need to be necessarily operating near the surface of the retina. Linda says, does laser surgery does laser surgery an option? I'm not well versed with what I think you're talking about, which is YAG vitreolysis, which is a laser procedure. I'm not aware that any retina specialist performs this. I know that there are a few doctors that do use this on select patients. It's my feeling that the patients that have the YAG laser done have a demonstrable or an obvious White's ring and a PVD. Without being able to examine you, I don't know if that's an option for you. Joanne says, my laser surgery made my floaters worse. FOV is better. I hear that commonly. Azem says, do you think that vitamins help reduce the deterioration of the macular degeneration in both my eyes? I cannot see with my left eye's central vision. Just want to save my right eye from vision loss. And what do you think about Crizal glasses? Do they help avoid the deterioration? I already made an examination, no retinal holes or detachment. I'm not aware that there are any vitamins that will reduce deterioration from macular degeneration. I had thought you said you had retinal dystrophy. If you have macular degeneration, there's really nothing out there. The AREDS vitamins may reduce the other eye from having significant vision loss, but those are only for specific patients, not everybody. It looks as though you've got a pretty complex situation, and it's pretty complex, too complex for me to answer kind of in this type of forum. Not so sure that any glasses will be helpful. They certainly won't help or change your prognosis with regard to deterioration. They may help you function better, but they have no influence as to the state of your eye. Edwin says floaters, cobwebs, and strands in front of the retina, most of them will go away with FOV. I would generally agree. Linda says, does this procedure increase risk of dry eye? In general, it does not, because we're not touching the cornea. Dry eye often occurs after, say, LASIK surgery or some types of cornea surgery or some types of cataract surgery where the nerves in the cornea are actually cut. So that basically desensitizes the cornea, and it interrupts the tear production pathway, meaning what we're interrupting is the dryness. The desensitized cornea can't tell the rest of the structures of the eye to make more tears when it's drying, because the sensory nerves have been cut. Edwin says the pressure in my eyes is 15 each. Like I said, I have a large cup, optic nerve, and no glaucoma. That's terrific. Sounds to me that you've been very diligent about getting eye care and following your doctor's instructions. Large cups can be indicative of glaucoma, but if you've been tested and you don't have any, that's just terrific news. Tuan says, I had YAG laser before FOV. This left me with some bright spots in my vision, which I only see when I look at the sky, especially when I blink my eyes. They fade after a few minutes. Are they retina damages by laser? I have no way of knowing what your retina looks like, but generally this would not be a result of the laser. I have no way of telling, is this permanent or can it go with time? I have no way of knowing because I can't examine you, Tuan. I'm not trying to avoid anything. It's just you're asking me to answer things that I need to know what your eye looks like. Meaning I need to examine you to answer those questions accurately. Edwin says, steroid usually has increased my eye pressure in the past. Is this an issue for FOV? No, it is not. Chrissy, do you want to chime in anything? We're getting close to the bewitching hour. We're almost at the end of our half an hour. Joanne says, I have an appointment with you in October. You're very competent. Well, you're very complimentary. I appreciate your confidence. I appreciate your attending the seminar and participating. Makes the whole product better. So email, Chrissy wants to emphasize, just email her, and then I'll be giving you Chrissy's email in just a minute, directly with questions about logistics and insurance. You're welcome, Joanne. Hazem says, do you think that hyperbaric oxygen thereby helps to treat the retinal dystrophy? Hazem, I am not aware that hyperbaric oxygen is useful for anything in the eye, or that there's anything that's been proven. So I don't know particularly whether or not it would help retinal dystrophy. I don't have any experience with it either. Edwin says, why do most eye doctors dismiss patients with floaters? That's a long complicated answer. I think mostly it has to do with, in many cases, doctors are unable to see the floaters. Number two, vitrectomy has a bad name in terms of doing damage. Most primary eye care doctors or general ophthalmologists don't understand the nuances of modern vitrectomy and how safe it can be. So I think that's probably a combination of why many of them don't think that this is a wise, they just don't want to deal with it. On the other hand, if you walked in their office and say, I can't see as well as I'd like, which is essentially what you're saying, if you have floaters and it was due to a cataract, you'd probably get cataract surgery very quickly. So, Edwin, I'm not so sure who that plea is to call, but I cannot call you. If you're asking someone else to call, that's totally cool with me. Soon says, are you still using 25 gauge? Yes. Do I plan to move on to 27 gauge? I'm not sure. I'm not sure that's a better solution for what I do. 27 gauge increases operating time, and I don't think that it's really not. It's not bringing to the table the change what 25 gauge did to 20. 27 gauge just sounds theoretically better. I'm not so sure there's anything proven as to increase safety. All right, well, I'm going to move on. Edwin says, are there stitches needed? Generally, even though we use 25 gauge, I like to use stitches at the end. Soon says, last question, after removing the vitreous, will that accelerate the formation of cataract? I read that is the case. You know, this is very difficult for me to answer because I understand that everyone says that vitrectomy automatically brings on cataract formation. I'd like to remind you, as I've said in various places, that that's just simply not our experience, and I can't speak to as to why other people will say otherwise. Would it be crazy if you got a cataract? Would anyone be surprised if you got a cataract? No. I'm just saying that in our experience, Very, very, very few people require cataract surgery within a year or 2 or 3 or longer after having vitrectomy. Sorry for my tough questions. My doctor said my retina was fine after laser treatment and the bright spots could improve with time. Well, there you go. I don't know why I couldn't have given you a better answer. My doctor could not see any damage with my retina. Well, then it sounds like this may go away with time. That's great news. Edwin says, I have immature cataracts. Yes, that's fine. As long as your doctor is able to see well enough into the eye to remove the cataract, vitrectomy should be very helpful. All right, I'm going to sign off. I want you to contact Chrissy at rwongcm13@gmail.com if you've got questions, if you've got insurance questions, if you need to know about the requirements for scheduling surgery and medical clearance. Edwin says, Joanne says, thank you. Thank you, Joanne. Edwin says, you're great. Well, I appreciate your attending. And Chrissy wants me to remind you that we're going to do this again in September. And we'll post this the next date on Facebook. I'm going to say goodnight to everybody. You're welcome, Linda. Thank you very much. I'm Randy Wong. Please visit us at retinaeyedoctor.com or vitrectomyforfloaters.com. Chrissy's email again is rwongcm13@gmail.com. And as always, I want to thank Mark Erickson of JiraDesign.com for providing all the terrific ophthalmic illustrations that I use during my talks. Anything else? Chrissy says, thanks everyone for coming. I agree. Thank you for attending, everybody. We'll see you next time. Good night.